Mrs. Chairman. My last topic for today is the assessment of tuberculosis risk in patients with inflammatory bowel disease and biological therapy. Why this? Huh? It's not working. Why this topic? Because the gastroenterology nowadays is in a world of continuous development with the burden of enteric infections, with endemic tuberculosis, and increasing incidence of IBD. Regarding the tuberculosis, it remains a major health problem worldwide because of the emergence of multi-drug resistant tuberculosis or highly resistant Mycobacterium tuberculosis. Also, as epidemiological data is estimated that 1/3 of the world population has latent TB infection, and the active disease may develop in patients with latent TB as a result of immune deficit, and today is responsible for about approximately 2 million deaths worldwide annually. Data of epidemiology in Europe show an average at 30 per 100,000 inhabitants. There are huge costs for treating tuberculosis, and only for 10 European countries other than Russian Federation there is a cost of $0.5 billion, and unfortunately 80% of this amount is consumed by 3 countries, including also Romania, Turkey, and Uzbekistan. A report of the World Health Organization for this year showed that in 2013, 9 million people fell ill with tuberculosis, and 1.5 million died from it. There is an estimated of almost 500,000 of new cases of multi-drug resistant tuberculosis, and even we have some achievements including the decrease in the TB mortality rate. There are still challenges, including amount of 3 million people who fall ill with tuberculosis still unreached every year, and the multi-drug resistant tuberculosis crisis. What risks do we face in patients with IBD? So these patients that are treated with anti-TNF alpha agents have 14 times higher risk of reactivation of latent TB. In addition, the combination with immunomodulators can further increase the risk of reactivation. It is known that the reactivation of latent TB occurs mostly during the first year of an anti-TNF treatment. The novel TB can occur at any time during the treatment in these patients, and mortality in TB patients during the anti-TNF therapy has been reported up to 13%. There is a chart in some studies, including the tuberculosis rates in patients receiving anti-tumor necrosis factor. There is especially in infliximab, and we showed that there are high percentage of extrapulmonary and disseminated disease. Who are the risk factors? Which are the risk factors for latent tuberculosis? It is established that the TB contact, homeless persons, intravenous drugs, the born abroad or residents in countries with high prevalence, and also there is a risk for institutionalized persons, for those working with them, even a person in the hospital. The progression from latent to active TB is also under some risk factors, and we can see here that there is a risk ratio for anti-TNF alpha therapy also. The biologics, and because we are now in the era of the biologics, work on the three mechanisms: inhibition of inflammatory cytokine, signaling, in particular tumor necrosis factor, inhibition of T cell activation or depletion of B cells. Increasing of their use and ever-expanding list of the new immunomodulatory therapies must draw attention to infection complications and also of tuberculosis. One of the established mechanisms for biological reactivation of tuberculosis during the treatment includes the fact that normally TNF alpha and some other cytokines are necessary for the stability of the granuloma, and under the treatment with anti-TNF therapy, the status of the granuloma is destroyed and the TB bacterium could be released. How we can reduce the risk? First step is screening. Screening for latent TB is essential before biological treatment. The second one could be the chemoprophylaxis, and the third one, the monitoring of the patients being treated with anti-TNF. Regarding the first step for the screening of the latent TB, we have four major means today. Is the tuberculin skin test, the chest X-ray, the interferon gamma release assays, and the skin test patches. All of them have some and disadvantages. Regarding the tuberculin skin test, it is concerning that the interpretation depends on the most important two factors. They can give false positive reactions and false negative reactions. The chest X-ray has a sensitivity between 59 and 92%, and a tool for screening FTB. And it is important that highlights anomalies on only 10 or 20 patients with latent TB infection, as some studies reported. The tests based on the release of interferon gamma, the well-known ALISpot or quantiferon TB Gold, they are good. They have a good correlation with the risk compared to the intradermal rectal tests, but all these tests were specifically evaluated on study on subject with reduced risk of latent TB infection. And in comparison, there are some advantages and disadvantages. We can say that for the intradermal reactive test is less specific, includes 2 visits, results in 2-3 days, and false positive results for patient prior vaccinated. For the other category is more specific antigen, needs only 1 visit, but is 4 times more expensive. The skin tests are still not fully validated in the clinical practice, so the actual effectiveness of screening for latent tuberculosis, current screening is obtaining through the history of the patient coupled with intradermal reaction and chest X-ray, but all this does not confer complete protection and seems to reduce the risk of reactivation of TB infections in about 80%. Here there is a slide with current recommendation of some very important and prestigious societies, stressing that history and examination, then the chest X-ray and tuberculosis screening tests are all important for this. Also, a study of the National Institute for Clinical Excellence London suggested that for latent TB diagnosis, testing strategy in 2 stages with an intradermal reaction followed in positive cases with IGRA test provides a cost-effective screening strategy. There are some possible situations that are shown in this possible algorithm. Regarding the second step, the chemoprophylaxis in patients positive for latent tuberculosis screening, we know today, and this is established by the ECHO statements, and that anti-TNF therapy should be postponed for at least 3 weeks after starting the chemotherapy. Chemotherapy for latent TB can vary depending on geographic area. There is not a single specific regimen. The recommended treatment regimens are ranging from 6 to 9 months, including different combinations of drugs. And patients receiving anti-TNF alpha after chemoprophylaxis should understand that this does not completely protect them from the development of active disease. The third step, it is the monitoring during the biological therapy. So anti-tuberculosis must always excluded, active tuberculosis must always be excluded in case of occurrence or persistence of fever or non-specific clinical deterioration during treatment. If an active disease is diagnosed, the anti-tuberculosis therapy should be started, and anti-TNF therapy should be stopped. But it can be resumed later if necessary. And patients with IBD traveling for more than a month in an endemic area should be advised to test themselves before departures and at an interval after returning. Patients with IBD and immunomodulation should be advised to avoid contact with TB patients. The IGRA test is the most important method for monitoring patients on therapy that received BCG vaccine and anti-TNF, then using skin test. And however, caution is necessary in recommending IGRA since predictive value is uncertain in immunocompromised patients. In conclusion, the emergence of anti-TNF alpha therapy has provided a new therapeutic approach, but it also brought new concerns regarding the safety. Its use is accompanied by the risk of reactivation of latent tuberculosis infection, usually shortly after initiation of therapy, often in the extrapulmonary sites, and not infrequently leading to disseminated forms. The screening reduces risk but does not eliminate it. Positive screening patients treated with anti-tuberculosis still keep a risk at about 20% for an active disease, and monitoring for activation of latent tuberculosis in patients with anti-TNF therapy must be vigilant. As take-home messages, we have to note that 1/3 of the world population has latent tuberculosis and 10% an active disease. Always assess risk, high risk, immunosuppressed, recent contact with TB, or chest X-ray lesions have to be taken into account. Attention of the interpretation of intradermal reaction, reevaluate, but there is still question how often. Close and permanent monitoring for patients with anti-TNF for tuberculosis or other opportunistic infections. Finally, I have to mention this thought of Niccolo Machiavelli, in its beginning, the malady tuberculosis is easier to cure but difficult to detect, but later it becomes easy to detect but difficult to cure. Thank you.
Thank you very much for this very nice overview. I was just wondering, what do the ECHO guidelines say on the screening?
Yeah.
What do they say, the ECHO guidelines?
The ECHO guidelines in the screening.
Did I miss it?
Sorry. For latent tuberculosis.
Yes.
Yes, they recommend the same approach. They recommend a clinical examination. They recommend one depending of the population and if was vaccinated or not, the intradermal reaction or IGRA test, and the chest X-rays and skin tests.
Okay, thank you. It's increased lots of my knowledge. So for a really shocking number, said 1/3 of the population have the latent tuberculosis.
Yes.
Yes, and so for, we know in Australia also the doctor, gastroenterology also concerned, have like an influenza that can associate to trigger TB. So is that if somebody already have a TB infection before, or they have vaccine, and then they still have a risk to get a relapse for TB, or what's the condition? So
yes, there is a risk,
yeah,
and there is the risk because of introducing some drugs that can activate the tuberculosis, can appear an active disease. As I mentioned, unfortunately, there are not 100% tools to identify latent tuberculosis and to know if the person was exposed before to a tuberculosis infection. This is why before beginning anti-TNF therapy, the patient has to be screened, but the most important is to monitor the patient during this treatment, because the disease can occur also under the treatment.
Okay. So another question is, what about the atypical tuberculosis? Is that anything associated with this treatment as well?
Sorry, I didn't catch the question.
It's called atypical. It's not a real TB, but the symptom, everything similar to yeah. Is there anything to do with the treatments with this immunosuppressant agent or not?
You mean that other forms that pulmonary tuberculosis, like intestinal or extrapulmonary tuberculosis, they have the same treatment as active tuberculosis, depending on the population, the geographical area, and this has to be ruled by the pneumologist depending the specific affectation of different type of extrapulmonary tuberculosis.